So now it is my pleasure to welcome our moderator for this evening's event, Sophie Louie. Sophie sets her alarm for 2:30 in the morning. As co-host of the Global BC Morning News, her favorite part of the job is the opportunity to learn something new every day. She loves that she has an occupational excuse to call just about anybody to ask just about any question. Sophie was born and raised in the Lower Mainland and has been a news junkie for as long as she can remember. She has been with the Global BC family for several years and co-hosts the morning news alongside her good friend Steve Darling. No stranger to UBC, please welcome back our good friend, our moderator tonight, Sophie Louie.
Did you want me to stand there? No. Okay. I didn't come in for the walkthrough, I guess. Well, thank you so much for having me. I'm glad to be back again. For those of you who were at any of the sessions that I've moderated before, I'm sorry, but I haven't written a new bio in a few years, so that's probably getting old. But I still set the alarm for 2:30. And Steve is a good friend. I don't have children, but I was one, and so I think it's somewhat relevant. Plus, Steve, my co-host, has 2 children, and I hear about their health problems all the time. Every little thing. It's great. I'm just kidding. It's all good. I live vicariously through him. So I was, pardon me, very interested in being a part of the evening tonight. So I will introduce you now to our panelists. Did we want to bring them up one by one or just all together? All right, ladies and gentlemen, please welcome our panelists for the evening. Hopefully I have the order right. We have Dr. Barbara Fitzgerald. She's a developmental pediatrician and the former Assistant Dean of Student Affairs in the Faculty of Medicine. She received her medical degree here at UBC, did a residency at BC Children's, a fellowship in education, and worked in the area of child protection and emergency pediatrics for several years before doing a second fellowship in developmental pediatrics with a focus on vulnerable populations and resiliency. Dr. Barbara Fitzgerald, right here. Dr. Kristen Houghton is a clinical associate professor in the Division of Rheumatology in the Department of Pediatrics here at UBC, a pediatrician at BC Children's Hospital, and a clinical investigator at the Child and Family Research Institute. Her primary research interest is physical activity and fitness in children with chronic disease, and in her spare time, she's volunteered as team physician for the women's national senior and youth soccer teams and at the Paralympics. Dr. Kristen Houghton. Dr. Margaret Colborn obtained her undergrad degree in kinesiology at SFU before entering the medical faculty at UBC in 1983. She then obtained her medical degree from UBC in 1987 and then completed a rotating internship at St. Joseph's Health Centre in Toronto. She did her pediatric residency as well as a fellowship in pediatric emergency medicine at both UBC and McGill. Dr. Colborn joined the medical staff at BC Children's in 1994, and since that time she's worked as both a pediatric emergency physician as well as being a member of the child protection team at BC Children's Hospital. Dr. Margaret Colborn. And finally, Dr. Edmund Chan from the University of Alberta Med School 99. And Dr. Chan is the head of the Division of Allergy and Immunology in the Department of Pediatrics at BC Children's Hospital. He's also a clinical associate professor at UBC. He created the UBC Pediatric Clinical Immunology and Allergy Fellowship Training Program and served as its first program director. And he is a fellow of the American Academy of Allergy, Asthma, and Immunology. Dr. Edmund Chan. And thank you all for taking the time, as Fred said. The first question that I have, and we will open it up to questions from the audience as well in a little bit, but the first question I have, because I work in the media, tomorrow morning I will go on the air and I will read what we call health headlines. And there'll be 20 to 30 second little voiceovers just saying something about some study that tells you to do this, and a lot of them will relate to kids. But they're so vague that I have a hard time feeling like we should be running these things sometimes. How do you, I don't know if you guys, if you pay much attention to what the media says about certain studies, particularly my form of media, because it is so short on television. But how do you deal with that, all this information that comes at parents constantly, plus through the internet these days as well, that may or may not apply to their children, may or may not be valid in any sense for their lives? And maybe we can just go down the line for that. Let's start with you.
That's a hard one, and I think it is confusing for people. How many of you are parents in the audience? So most of you. How many of you think you will be parents one day? I often ask the medical students when I first start talking to them about child development, what do you think the most important thing is that runs through a parent's mind when the doctor delivers a baby and tells them, you know, you have a baby girl? What's the first thing they want to know? Is she healthy? And then after that, is she doing the same things that her cousin is doing at that age? Is she keeping up? He learned to walk. My kid hasn't learned to walk. She's talking. Should we go to Kumon Math? Because he's going to Kumon Math. And then you get this deluge of media things that Sophie's referring to. And how do you make sense of it? And I think, you know, parents sometimes forget that they have an awful lot of common sense and innate wisdom. And I think one of the best pieces of advice I could give to parents is to just think long and hard about things that you hear, new things that people are suggesting that you try, new diets for your children, new tutoring programs, all kinds of things that are suggested, and just put them through your own lens of common sense. You're the expert about your child. You know them better than anybody. Mm-hmm. And so really to think about who your child is and what's going to be best for them and what makes sense. And think about what your grandmother would have told you.
Wise words. So one thing I did neglect to run through with all of our panelists is to allow you as well to explain to our audience a little bit more about your area of expertise. So if you want to do that in addition to answering the question.
Can I go again then?
Yeah, you sure can.
I want to tell you what, because most people wouldn't know what developmental pediatrics is. So I'm the branch of pediatrics that looks at child development. So when I ask that question about what's the second thing that you're worried about, and it's, is my child normal? And so people come to me when they're worried that their child isn't developing in a typical way. And I help them with that. And my biggest interest has been in two areas, really. One is helping parents to understand their children. When children are understood, then people are more patient with them. So if your child is late to talk and you've been thinking that they just aren't listening and are being bad, then it can really help you to understand your child when I can explain to you about why your child seems to be not listening. So I spend a lot of my time just helping parents and teachers understand their children, who they really are, and how we can help and support them, and help them to understand that there aren't really any bad children. And then the second thing that I'm most interested in is in how we as a community, all of us, can help protect the vulnerable children in our society, and to understand why that really makes a difference for us as a whole community when all children in our city and in our province have enough to eat and have clothes to wear and get everything that they need to grow up healthy.
Okay. Kristen?
So I'm a pediatric rheumatologist and sports medicine physician at Children's. Most of the time I actually work in rheumatology, which is taking care of kids with arthritis and other rare diseases like lupus. But I also do sports medicine, and that's primarily why I'm here tonight, so to talk about things like injury prevention. And I'm very interested in healthy, active living, promoting physical activity, preventing injury, managing concussion, and ensuring that kids can be healthy and active. And the other question, I think, was brilliantly addressed by Barbara. But I also try to provide some trusted information or websites to families as well, because there's a lot of information out there. Some of it is misinformation. So trusted resources like the Canadian Pediatric Society has some great information that's written for parents. They can also look at information written for physicians, depending on their level of that they want to delve into things.
Okay. All right. Margaret?
Sure. So I'm a pediatric emergency doctor, and so that kind of makes me a mini specialist about a lot of things, but not really smart at any one thing. But if you can kind of divide what I would see in a typical day under two headings, one would be illness and one would be injury. I had a bit of a chuckle at the title of the talk, The Healers, because I really actually don't feel I do a lot of healing. I do a lot of convincing parents that their kids are going to heal themselves if you take a big step back and let them do that. And they don't need a lot of tests, and they certainly don't need a lot of medicines. And they actually do really quite well. And then spend some time talking to them about what to watch for, what I would worry about that might lead to maybe some more investigations or tests or interventions. But most kids really are quite resilient and phenomenal about getting better on their own. Certainly the most common complaint that we will see in Emerge, 25% of what we see, and we see about 40,000 kids a year, is fever phobia. When a kid has a fever, he's going to get brain damage. And so we spend a lot of time talking to parents about fever and the fact that most of the time it's infection that's triggered that fever, and the fever is a good thing. It means they've got a functioning immune system that's fighting off whatever germs triggered their fever. So a lot of what we do is really counseling. With respect to the misinformation that's out there, I would concur with Kristen, the Canadian Pediatric Society, which is cps.ca. Very great website. There's a specific area in there for parents called Caring for Kids, and they have got information on there about absolutely everything. So that's, and on that area that's for parents, links to other websites. There are, interestingly, at least two files on there that specifically address how to get information off the web and how to judge for yourself whether or not you think it's reliable. And they give you little tips with respect to what you should see in a reliable website and that kind of thing. So I would agree. It's a good one to check out.
Edmund?
So I'm a pediatric allergist, and so I'm a physician who sees children for confirmation of whether or not they have an allergic condition, for diagnosis of what specifically they're allergic to, and for management of their allergic conditions. And the conditions I'm talking about are mainly food allergy, asthma, atopic dermatitis, allergic rhinitis. I also have a special interest in eosinophilic esophagitis, which is a growing concern.
What is that?
That is, just to describe it briefly, is inflammation in the esophagus, and it's an allergic type of inflammation. So when you look at the cells responsible, it's an allergic type of cell, and it interferes with eating, the process of eating. So the children have difficulty swallowing, and they have vomiting, and it's quite an impact on quality of life.
Yeah. Okay.
So, I mean, clinically, that's what I do, and it's fascinating. It's very dynamic. It's changing all the time, but it's a very, very strong privilege to be able to work where I work, to be able to teach students and trainees at all levels and do research, especially in my interests of food allergy and eosinophilic esophagitis. Now, this question about the latest news story and went on to be a discussion about myths and misconceptions. Unfortunately, my field is really quite rife with misconceptions and myths. And what really struck me even today was on the news, there was this Toronto Star article, and it's been in other articles. There's the chair of medicine at University of Toronto is starting an initiative for Canada on the problems of over-testing and over-diagnosis and over-investigation. And that's based on an initiative that was started in the United States a few years ago. And that has grown in the U.S. to involve 50 different specialties with just very brief advice for physicians and the general public, like 5 tests to think twice about and to maybe not do. in case that might lead to side effects. It might lead to medications being prescribed with side effects or interventions with unintended effects. And so I like to have that sort of discussion with parents quite often when we talk about these things, that it's better off when it comes to allergic conditions to not do a test than to do a test, and I explain why. And when it comes to the latest studies, trying to go over the the tidbits in that study and explain why one single study doesn't change our practice, and it requires many levels of evidence and many pieces of evidence to change our practice.
I do want to get back to more about food allergies, but you talked about overdiagnosis, and that I think maybe you might all want to address this too, but perhaps particularly you, Barbara, because we've seen numbers go up in recent years in the diagnosis of things like ADHD and autism and other disorders like that. So is it that there are more children who have those disorders, or is there such a thing as overdiagnosis? Are we just recognizing it and giving it a name now? Or did it always exist?
Well, those are two very different conditions. And so the autism one is a little bit easier to address. The criteria for making the diagnosis of autism has changed, and it has included more people, more children under the autism umbrella. So part of the rise in the numbers of kids with autism is that we've changed the criteria for diagnosing it, but there does seem to be a true rise as well, and we're not sure why. With ADHD, there's been an exponential increase in the number of children diagnosed. Just from when the DSM-3, so the Diagnostic and Statistic Manual that's used mainly in the field of mental health, but also in child development as well, for making diagnoses like things like depression, attention deficit hyperactivity disorder. Just from when the DSM-3 got replaced by the DSM-4 back in '93, it led to about a 25% increase in the number of children diagnosed with ADHD in the U.S. We have the numbers from the U.S. And now the DSM-5's just come out, so we're kind of expecting it might increase again. And it is a bit of it's a real concern, and there's a really interesting thing that's starting to happen. People are starting to question these kinds of diagnoses and why up to 10% of children are being diagnosed with a condition with a recommendation for a pretty serious kind of medication as a treatment, so that, in some places, 1 in 100, sometimes even more than that, are being treated with Ritalin-type medications. And there's a lot of really good questions being asked about that, and we don't know for sure. Is the incidence of children who are having difficulties coping in daily life actually rising? Are we expecting more of children? Are we expecting young children more and more to do things that we didn't expect them to do in the past? So for some of you with kids in kindergarten, you'll notice that when you go into a kindergarten class now, children sit at desks, and most of us never sat at a desk in kindergarten. We weren't expected to learn to read and write in kindergarten. We played in kindergarten. So some of it might be changing expectations. There's another really interesting thing that people are looking at. In the most recent edition of the DSM, for the first time ever, the people who are writing the DSM have been asked to disclose their own private interests. And it's a really common thing in medicine. Whenever we talk, we have to say, like, if I'm standing up here tonight to promote the diagnosis of autism, you might want to know whether I'm getting some kind of compensation for the number of kids who are diagnosed with autism. And we now know, because they've had to disclose, that up to 70%, around 70% of the people who are on the board of writing the DSM are actually get a certain amount of their funds are paid for by drug companies. So that's something we all need to know and we all need to think about, because there hasn't been a lot of research. There's been a lot of research into treating conditions like hyperactivity and attention in children with medication. There hasn't been very much research that's been done on looking at things like exercise as a treatment for ADHD, or mindfulness techniques, or other things that are starting to show some promise. So it's a huge area that we need to think more about and do a lot more research in. Personally, what I see is children who are often coming in where expectations have been too high for them. Parents have put their children into a number of different programs that are way beyond what any young child can cope with. And sometimes just a stress response can look like something like attention deficit hyperactivity disorder. So I guess that, I could talk all night about this because it's really kind of a bit of a real area of interest for me, and I won't. But I will say that for any of you who are going through a process of getting a diagnosis of ADHD for your children, make sure that you ask to see a specialist, because an appointment in 15 or 20 minutes won't diagnose ADHD. It's not sufficient. There are too many other things that can present with the same kinds of symptoms that children with ADHD have. And you want to make sure that you rule out those kinds of things.
Do any of you have any follow-ups to that? By the way, I should have mentioned this to you before. If you want to jump in on one of these questions, you're more than welcome. I also want to talk about prevention, and we are focusing, I think, a little more on prevention in healthcare these days, not for adults as well. What about prevention for children? And I want to start maybe with you, Margaret, in a more a general sense.
Sure. Illness and injury. So illness, immunize your kids and wash your hands. And that's about it. and injury, be active. Your kids have to be active. They have to develop their muscles and bones, develop their sense of balance. They have to be active, but they have to do so with some kind of education. And so when they're young, you're the educator. And so you've got to learn about the activities that you put them in. And when you start hopefully doing activities with them, you yourself have to make sure you've learned as much as you can about those sports or things that you're going to take on. And you use appropriate safety equipment like helmets. So that's kind of about it.
Wash your hands. All right. Well, talking about being active, and that would lead nicely into Kristen being active. Where do you fit prevention into your delivery of healthcare?
But I think prevention is the most important thing for sure. So there's different levels, and it depends on the kids that we're seeing. Probably the biggest problem that we see in terms of globally of child health problems is obesity. Mm-hmm. And one of the strategies for that, of course, is physical activity. It's just one part of it. So promoting physical activity for everyone, I think, is really important. And we know that overall we don't do a very good job of that. Only the latest studies out showed only 7% of Canadian kids actually meet our recommendations of 60 minutes of activity a day. So clearly we're not doing enough. So that's for all comers, and particularly for children who are struggling with being overweight or obese. And there's a different group of problems that we see as well in children who are active, and trying to allow them to be active in a safe way. And the biggest problem that I see is, well, approximately more than 50% of injuries are overuse injuries, and probably half of those are preventable. So despite there being overdiagnoses in lots of things in medicine, I think a lot of times children are seen with a sprain or an injury, and they go back to playing without being properly rehabilitated or having rest or being educated about that. And that goes to proper movements and being trained appropriately. So that's a big area of focus. And there's some specific examples that have been really helpful and effective. So soccer's the most popular sport in Canada for kids. Hockey might be the most fanatic, but soccer is the most popular for numbers. And there's some simple warm-up programs that if you do those instead of a regular warm-up program, you can cut your risk of injury by 50% in serious injuries, so knee ligament injuries that could end the season for a young athlete by 30%. So it's very, very simple strategies can be put into effect quite easily once people are aware of it.
Okay, we're going to talk more about prevention and your work with Hockey Canada as well, just a minute, but I want to let Edmund and Barbara answer that question, the prevention question as well. So Edmund?
So allergy prevention can get quite complicated because allergic conditions are multifactorial in nature. So there's a genetic predisposition, and there's a variety of environmental exposures that can increase the odds of resulting in an allergic condition. Where most of the efforts have been centered over the past decade have been on dietary exposures in infants and allergy prevention. So discussion about breastfeeding, duration, when to introduce solids, and which solids to introduce first, and those sorts of things. And what has been done recently is through the Canadian Pediatric Society in December, I published along with some collaborators a position statement through the Canadian Pediatric Society on allergy prevention and dietary exposures. And it was the first time that Canada had this type of position statement, and it largely was with the primary objective of stating that there's no benefit to delaying foods of any sort, including foods with peanut, beyond 6 months of life. And so that was the primary message we wanted to get across. We're seeing many, many families still who are hanging on to older advice to delay. And then so you have families coming into the office thinking that they need to delay introduction of peanut or fish or egg or whatever food you can think of until the child is much older, like 3 years of age, for example. So hopefully...
Is that even though their own pediatrician will tell them, but will tell them about the new guidelines, they still stick to the...
Yeah, so we've done some studies even at our clinic. We surveyed pediatricians in BC and dietitians in BC, and had another resident who then did that same survey in Atlantic Canada, and the results were all over the map. So you did have practitioners saying delay until 3, and then you also had practitioners say don't delay. And so what that suggested to us was that there still is quite a bit of education needed, not just of the general public, but of healthcare providers. And it's actually a fairly difficult issue to tackle because there's so many different healthcare providers at different levels. There's family physicians, there's specialists, there's dietitians, there's public health nurses.
And then there's all the people that the parents know who are telling them all sorts of things. You should do this or you should do that. And
exactly.
How do you
family,
filter it
friends,
all?
the internet.
That internet. Okay, Barbara, so we're talking about prevention. And
So we don't want to prevent child development.
No.
But how do we promote healthy child development? And, that starts off really early on by taking the time to have space in your life for your children. There's some really interesting work now that's showing that stressed mothers and stressed fathers actually change the way that the DNA in their babies works. And we've even looked at DNA in 15-year-olds and found that it's still got the imprint of the mothers and fathers' stress from when they were little. So you need to be healthy too. That's number one, to raise healthy children. And you need to read to them, number one. And you need to get them out exercising, as my colleagues have suggested. When kids exercise, their brains grow. It actually causes a factor in the bloodstream, a hormone that makes brain cells grow. So we have some people that think that kids playing and kids exercising is taking away from Kumon math and Suzuki violin time, when they could be doing things to get ahead of all those other kids. And actually, those other kids that are out running around are growing their brains. So safely, as has been said, but they do need to exercise. And you need to create a home where there's space for your children to be calm and to enjoy the love of their family. Because we're starting to see now how it's not just about what you do to your kids, but it's the environment that you create for them actually changes the way that their brains grow and develop.
Kristen, we touched on it briefly, talking about kids getting out, being more active, kids playing soccer, kids playing hockey. Now, you worked on new body checking guidelines that were adopted by Hockey Canada. Can you tell us just a little bit more about that?
Sure. So as part of the Canadian Pediatric Society, I work together with Carolyn Emery, who's an expert in injury prevention. She's actually a PhD physiotherapist. And the reason it came to light actually was there was several comments or emails to the Canadian Pediatric Society from parents asking for some advice or input into this area. So I'm on the sports medicine committee, and we decided to take that on. And it was interesting because it quickly became apparent to me that many Canadians are passionate about hockey, and including in the policy decision-making, a lot of decisions were based on emotion. And we reviewed all of the research that was out to date, and I put that together, and then having it endorsed by the Canadian Pediatric Society made it a lot easier for us to have leverage when you lobby provincial organizations and then the national organizations. So essentially what we found is there was definite increase in injuries in children who play in body checking leagues. So this is only boys. Girls play in non-body checking leagues. Body checking accounted for anywhere from 50 to 80% of injuries. There was 3 times more injuries with body checking, 4 times more concussion. So quite striking numbers. And when we approached Hockey Canada, it actually was much easier than I expected.
Really?
We published in December 2012, and they changed the rules in May 2013. So I think just having the evidence for people to look at made it a lot easier for people.
I would have thought because hockey is such a big part of our culture and because it is such an emotional debate that it would be tougher for that.
It was contentious. I mean, there's a lot of people who strongly believe that if you learn body checking earlier, it may protect you against injuries later on. And that was the most common argument against delaying body checking. So the rule now is at age 13 that it will be introduced. But there was some really clever studies done looking at children who start body checking at age 11 and 12 comparing to those who start at 13, 14. And there was clearly more injuries in the 11, 12-year-olds. But then following them up and seeing, well, if you learned it earlier, did you have less injuries when you were older, when you were 13, 14, 15? And actually it wasn't protective. So that was very helpful in sort of swaying the naysayers.
Right. Okay. So that, I mean, that was successful for you. What other policies would any of you like to see changed or adopted or done away with?
$10 a day daycare for all children. That's what I would like to see.
Okay.
I would like to see every child in our province have access to good quality daycare so that their parents can go to work and with peace of mind and children aren't being left in unsafe situations. So if I had to pick one thing, that's what I would say.
Okay. How about you, Margaret?
For me, it would be sort of an extension of the bike helmet philosophy. One of my projects during my Peterage Fellowship was, in the early 90s, was bike helmets. And I think the legislation came in late 90s. But we just saw, the neurosurgeons like to show their bar graph slide of the disease they cured because the hospital admissions pre-bike helmet for serious head injury were really significant. As soon as that legislation came in, they just plummeted. So bike helmets really do help protect kids' heads, and their arms will heal. So, what I would like to see, though, is that extension, not just necessarily of helmets, but of legislation that would address other recreational motorized vehicles. Because although children's use of ATVs and skidoos and sea-doos is not huge, it is more than you would think, and there really is no or very, very little legislation with respect to age restrictions and safety equipment they use, like helmets. And the injuries they get from these motorized vehicles are so substantial. Significant death or significant impairment. So those were the ones I would kind of like to see addressed.
And in your line, of course, you would see that a lot more than... Okay,
so I would like to see, and I was alluding to it earlier, tighter regulation and greater public awareness of the pitfalls of food allergy testing. Because we all hear about so many friends and relatives and other individuals who go and get food allergy testing, but there's much of it that is not evidence-based, and much of it that's been poorly selected and poorly interpreted, and the end result is this label of food allergy where it shouldn't exist. And so that's why I mentioned this choosing wisely Canada, that's what it's called, this campaign that Wendy Levinson at University of Toronto was starting up. I actually have been in touch with our professional society earlier today about getting the Canadian Society of Allergy and Immunology on board with that campaign to try to reduce the number of tests that are done generating these labels.
Right. And are you seeing more, I don't know if this would come straight to you or not, but seeing more families who are doing things without even testing, going gluten-free or going dairy-free or doing so-and-so free, things like that?
Yeah, definitely. I mean, there's studies that have described numbers of individuals doing that, and then, yes, in the clinic setting, you see it every day. People, just because of reading something on the internet or hearing something from a friend, removing, usually it's milk and wheat from their diet. That's what they do first, but a variety of dietary restrictions that are unnecessary and not evidence-based, with the potential harm of malnutrition, poor growth in a young child, and extreme anxiety. And that's something that we're looking at more and more in my area of practice. We brought a guest speaker for Grand Rounds at Children's Hospital in January talking about the burden of food allergy and how too much awareness and too much diagnosis can generate huge levels of anxiety.
Okay. Something else that we should talk about is what happens to our children when they're children can affect them later as adults. And for instance, sunburns with children could lead to, is it a higher likelihood of skin cancer, a higher possibility of skin cancer when they're adults? So what other things do we need to watch for as parents in our children that would affect them or could affect them? Probably most things, but more specifically like sunburns and skin cancer. Who would like to tackle that one?
I would say the biggest thing, again, from a population health perspective, is obesity. We know that obesity is related to heart problems and strokes and osteoarthritis, diabetes, some types of cancer, and up to 30% of Canadian children are overweight or obese. And we also know that children who are obese are likely to be obese adults. So there is a real concern that kids growing up today are going to have that increased burden of obesity-related diseases. And it's a very complicated problem. Obviously, otherwise we would have fixed it by now.
Yeah. Anyone else?
Well, one thing that might not apply to your children, because I hope that alumni of UBC are not living in poverty. But it affects us all as a province, because we all know that the costs of health care are going up and up and up. And children who live in poverty are at much higher risk. Children who live in poverty and children who experience trauma as children and high-stress home environments. Research that's come out of UBC, a lot from Clyde Hertzman and Tom Boyce, they talk about how poverty can get under your skin. And when we look at children who grew up in highly stressful environments, experienced trauma, or children who grew up in poverty, and we look at their burden of disease as adults, so if we look at the common killers of adults, cancer, diabetes, heart disease, you're much more likely to have those conditions and die earlier if you grew up in trauma. So there's this amazing study of doctors who graduated from Johns Hopkins University. So amazing from medical school, amazing medical school. One would expect that most graduates of Johns Hopkins University would go on to be pretty successful physicians and certainly not poor. And they looked at the ones who had actually grown up in poverty, because they take it's a little bit easier to get into good schools in the United States. They have a better bursary program. So some poor people can get into really good medical schools there. And they looked at their incidence of disease later on. And those guys graduating from Johns Hopkins with these wonderful degrees, the ones who had grown up in low socioeconomic status homes, were much more likely to die young. And so if we even aren't thinking about it from a humanitarian perspective, just from an economic perspective, it's not making any sense to keep our kids poor because of the burden of disease later on and what it's costing our healthcare system.
You're nodding, Margaret.
Yeah, there's a whole field of new research called epigenetics, which focuses on, as sort of what Barb's talking about, how the events that we're exposed to in our formative years as young kids not only change the expression of our genes, but they can actually change our DNA and that of our children. So it really is, it's going to be quite interesting to see the research that comes out in the next 10 years or so and how they build on this, because we really have to address it much, much better than we've been doing.
So child poverty, obesity, we talked about some of the issues that I think a lot of us have heard about in the news, we've thought about for our children's health. What are some other conditions that you think need more attention?
I have to jump in just with one, because it goes back to one of your questions before about, if we could change one thing. And I just like to say as often as possible, because this is another myth that comes up in the media, it's not safe to drink alcohol in pregnancy. Just plain, simple, don't drink alcohol in pregnancy. And there are still doctors out there and midwives who will tell you, it's okay, just now and then it's okay in the third trimester. No, just don't drink alcohol in pregnancy. It absolutely will not help your baby, and it very, very might likely hurt your baby. So that's one thing I would like to say, because we have a lot of children who are exposed to alcohol. In some of our communities in British Columbia, we have an incidence of fetal alcohol syndrome that's getting up to 10% of children. In some communities, even 25% of children. So just don't drink during pregnancy. And every time you see one of your friends or relatives who goes to have a big glass of wine when they're pregnant, take it away from them.
Okay. Who else would like to address? Well, you can talk about drinking in pregnancy, but an issue that concerns you, and perhaps it is that or obesity. I mean, it's some have said the most pressing problem that our children are facing. Sorry, go ahead.
Well, I could mention that one of the explanations that's been suggested for quite a long time now to explain the rise in allergic conditions over decades has been the hygiene hypothesis. And so it's interesting that we're talking about the negative effects of poverty at the individual level, but at a societal level, paradoxically, it's felt that affluence, so being raised in a developed country like Canada, dramatically increases your chance of developing an allergic condition. So there's something about the immune system that isn't educated properly in early infancy when you're raised in a place like Canada. So the hygiene hypothesis suggests that we don't have the right mix of germs in these countries. It's too sterile, and so that's one explanation. That extends to the types of fatty acids we have in our diet, like maybe there's not enough omega-3, perhaps there's too little vitamin D exposure. It's just, there's something about our whole lifestyle that when you add it all up is very conducive towards these chronic conditions that depend on a functioning immune system. And that window of opportunity that's often described in research could be as early as 3-4 months of age. And once you're past that, you're already set down the path of allergic inflammation.
Margaret?
The one thing that I just wanted to comment on was mental health issues in kids. It can't get enough attention because we don't talk about that kind of stuff very well at all. And it certainly is getting more attention, but it still needs more. And we are seeing a lot of young kids with sort of the more minor side of mental health issues, anxieties and phobias, but also some of the more severe mental health conditions like major depression. And it is very, very difficult to access appropriate community resources because, quite frankly, they're just not there. And so, unfortunately, in Emerge, we're seeing families arriving just in crisis because they've been on a wait list for 6 months to a year. And when a child's only 6 years old, that's a long, long time to be waiting for assessment. So that's certainly an area that I would like to see get a lot more attention.
Yeah, definitely. All right, Kristen?
I think there's been a lot more attention about sport injury in general, and especially concussion, given some high-profile athletes that have had concussion. But I think there's still a fair bit of misunderstanding, and that we're probably underdiagnosing it. The biggest misunderstanding, I feel, is that you need to be knocked out or lose consciousness to have a concussion. Well, in fact, most people who have a concussion didn't lose consciousness at all. It's just one of the potential symptoms. The other thing is any child who you think had a concussion, so if they seem a bit dazed, have a headache, aren't themselves, should be seen by a physician. And there's very clear resources and sort of stepwise return to activity, including returning to school. So they need to rest their brain, not think, not play video games, not exercise till the symptoms go away. And at a minimum, it means children going back to sport in a week. Mm-hmm. And I know that's not happening on the general playing field. And there's more and more children being recognized with symptoms that are lasting longer or having second concussions.
Right. And then that can affect them into adulthood as well.
Mm-hmm, yeah. Definitely.
All right, I think it's about time to start asking for questions from the audience. So we have a couple of microphones that we're going to be circulating throughout. And I should have worn sunglasses so I can see you all better.
I'm right here.
Oh, there you are.
And Anne's on the other side.
Okay. So just raise your hands, and Anne and Fred will come by.
We've got one right here.
All right, go ahead.
If you can stand up.
Hi, thank you so much for doing this for us alumni. I was just wondering, at what age do children stop being susceptible to the genetic change that they experience in their environments and the events that they go through when they're children?
So at what age do they stop being susceptible to the genetic change from stress and things like that? I don't think we know the answer to that. We've studied the long-term effects of it from early infancy, when we think children are most susceptible. It's interesting. Mothers' stress and their emotional state have the most effect on children when they're infants. We see the biggest effect there. Fathers have a bigger effect when the children are preschoolers. I don't know why. Maybe someone can think of some logical reason for that, but it's kind of interesting. But this is one area where fathers don't get off the hook. Usually the fault is all on the mother. This is one where fathers don't get off the hook. I think that the environment in the family affects a child long term. We just haven't looked at specific epigenetic changes that I'm aware of later on.
Hi, Patricia Porter. I come from education. I got to UBC late in life. That was quite fun. So it's a bit daunting talking to a medical group. And my question was going to be for Dr. Fitzgerald, but it might be relevant for all of you. My concern is the medicalization of behavior in children. I mean, when I was teaching in the classroom, we knew that if a kid went to Sunnyhill with measles, he would come back with ADHD. That was just well known within the education community. Somebody's talking about obesity. When is it behavior? When is it medical? And in terms of how this is defined, who does it let off the hook? Who gets away with it? If maybe you understand what I'm saying, but parents often are desperate to get their kids labelled because then it avoids them having to work in a certain way with them. Teachers, if a child has a label, often think, fine, somebody else can fix it. And I'm just interested about that interface and what people think about that.
Okay, I won't talk all night about that, but that's a really good question and comment. And there's nothing like an experienced teacher to tell you, especially a teacher who was around a few decades ago, to say, boy, when I had a little boy in my class who was squirmy and fidgety and couldn't pay attention, I'd tell him he had to do these 5 questions, and then he had to take a special note to the office for me. And he'd run down the office, and he'd have his special note to hand to the principal that would say something like, "Hi." And then he would come back. And then the next 10 minutes later, they'd say, I think you really need to go and get a drink of water. And we didn't call it something abnormal. And it's such an important point you bring up, because there are kids who truly have significant disabilities that we want to know about. I want to know when a child has a specific learning disability so that we can provide support rather than call the child lazy or he has a bad attitude. But when we are dealing with the normal range of child development, we need to cut kids some slack. And so when you say who's responsible for that, the adults are responsible for that. So the parents are responsible for making sure that their children sleep at night, that they have healthy food, that they have access to exercise, and all the kinds of good things that we know children need to grow up healthy and be ready to learn when they get to the classroom. They need to not be playing video games and have screen time like so many of our kids do. The Canadian Pediatric Society recommends 1 to 2 hours a day. And there's no need for any amount of screen time. But that's what we're sort of setting as our maximum amount. Kids who are coming in having already played 3 hours of video games before they get to school, they're not in a frame of mind where they're ready to learn. But we do need to cut kids slack in terms of normal development. We used to, for years, we've been looking for the cause of ADHD. And one of the things we've looked at are brain scan studies, MRI results. And for years we've said, we think that this part of the brain is abnormal. We think that part of the brain is abnormal. But we could never come up with a consensus. One study would never find what the last study showed. And the most recent one, what it's shown that really makes sense is that the part of the brain that naturally develops later develops even later in kids with ADHD. It doesn't develop abnormally. It develops later. And so some children haven't read the child development textbooks, and they might not be ready for what we think they should be ready for. So we have to accommodate children and be respectful of children. And as parents, we have to do everything we can to make our kids ready to learn. And that doesn't mean more tutoring or more programs. It means really basic things like exercise, sleep, and a loving family. So I don't know if that fully answers your question, but I think that you are raising a really important point about us providing too many labels for children instead of trying to provide understanding and support and figure out how we can help them. And making too many children, giving them diagnoses that imply that there's something neurologically wrong with their child, when actually they're developing in their own way at their own pace.
Anne?
Hi there. First of all, thank you for being here. My question has to do with excessive use of computers and how it affects our children's development. I've got 2 daughters, ages 8 and 10. And as a parent, I find it really stressful to try and balance, schoolwork, a little bit of computer time, reading, physical activity. There's not enough time during the day to try and fit everything. And I finally installed a timer on our computer so that after 45 minutes, time is up, and then the other one has a turn. But yeah, it's taken this long to get to that point. It's a constant battle.
Are your children very physically active?
Oh, yes, they are. But, they want that computer time.
Yeah.
So can any of you any comments?
Well, I think the 1 to 2 hours a day that's been recommended by the Canadian Pediatric Society is a good limit. What's really hard is when your children get older and they're using the computer for homework. And that's a little bit different. So I think what we're talking more about here is when children are using computers and other gaming devices, their DS. What you have to ask yourself is, what would they be doing if they weren't doing that? So if they're doing homework, that's something different. But if they're playing a video game, what would they be doing during that free time if they weren't playing a video game? And hopefully the answer is They'd be building something with Lego. They'd be drawing or creating something. They'd be outside running around playing a game. And ask yourself, which is going to be better for their development and their health? And in most cases, it's probably going to be one of all those other things. So I have a slide that I show the medical students of two babies sitting like that in front of a television set watching. And, I entitle it, "This is what kids do when they're not developing." And so, we have to use those electronic devices to save our own sanity. We have to cook dinner now and then. And definitely it's better, and Margaret, as head of the Child Protection Unit, will attest that it's definitely better to put your child down in front of a video than to scream at them or hit them. Definitely better if you need that for your sanity. But when they're watching television and when they're playing video games, they're not developing. So think about other things that they would be doing that would be using their creativity and imagination. I know that there's studies that have come out that have said, oh no, your children are going to learn to read quicker. All of that Sesame Street stuff, even from the 70s, it hasn't really turned out to be true. So kids learn best by play. And so we want to see them playing.
And just one further comment about the screens. They should not be in their bedrooms.
Yes.
They should not be in their bedrooms. None of them. Don't let them charge them in there. Don't get them out of there. They've got to sleep. They have to sleep. It is amazing how many adolescents we're seeing in emergency that have, unbeknownst to the parents, have slipped into this reverse cycle of they're up all night with their screens while the parents sleep, and then they can't stay awake in the day. And it leads to difficulties in school and depression, and just get those out of their bedrooms.
And no screen time 1 hour before bedtime for any age, even you guys.
All right.
Sophie, we have an online question. Research, risk-benefit of vaccination, and what are the most common vaccinations for children?
Okay. Vaccinations. I mean, that was something that I had been wanting to bring up when we were just talking as well. That might be something you would want to talk about, Edmund? Or?
I could, in the sense that...
I've already told you you better not contradict me.
No, but we get a lot of parents coming into clinic claiming that they shouldn't immunize their child because it might cause autism or whatever untoward, or even when it comes to conditions that I see, it might actually cause the allergic condition that they're worrying about. And so it's steering them towards resources that describe what the benefits of vaccinations are, which are very, very well described in the literature. And the Canadian Pediatric Society, for example, has many resources available to parents on each individual vaccine and the benefits and the risks of each. It's shocking that our vaccination rates in children are as low as they are in some areas when we know so much about the benefits. And so it's taking the time to explain, but it's a very difficult discussion quite often because often, and it's not just for vaccinations, but we find that this concept of the N of one. So when someone goes up and speaks about their child who had a problem, it just, overwhelms everything else. And you can't talk about the studies because they're not as attractive to talk about as this one case.
Or sometimes the study is faulty and is published.
And that's what happened in the case of autism.
That's right.
And I think that was probably one of the most damaging things that was ever published. There was a study that was published in The Lancet, so a very well-reputed journal, that linked the development of onset and the increase in number of autism cases to vaccines. And it subsequently has been retracted. The data was not accurate. It was not at all an accurate study. But it did a lot of damage, and we're still seeing the ripple effect. The link between autism and vaccines is actually, apparently, I'm told, the most studied thing in medicine ever. No, there have never been as many studies as there have been in that, and there's no link.
There is no link. No link.
No link at all. But what there is there's a temporal link. So you could also say that, toilet training causes tantrums. Because you toilet train right around the same time that your kid starts having tantrums. But actually toilet training doesn't cause tantrums. And you get immunized right around the time that children get to a developmental stage where you can start to appreciate the features of autism. And it's, as a parent, you're just looking for what could have caused that, because my baby seemed so normal before, and then they had their vaccine, and it seemed to have caused it. So they're linked in time, but they're not. Vaccines do not cause autism. That's one thing. We rarely in medicine say, like, we know something for sure. But we know this for sure.
So, I mean, that Lancet, the Lancet retracted that article. There was a lot of media about that when the study was disproved. But are you still seeing numbers as high of parents who won't vaccinate their children?
And this whole concept of developing natural immunity. Your immune system only responds to what it is exposed to. And we are such a well-protected population that they're not going to find measles very often unless they pop up to SFU one day. So they're really just only one airline flight away from all these illnesses. Yeah. So there's about 20% of people that will choose not to vaccinate for various different reasons. Sometimes they just kind of don't get around to it, and they've heard this and that's bad. But if you sit down and talk to them about it, you can convince some, but not all. There's still a small percentage that absolutely will not. But it is very important that they know that their children are very unlikely to develop natural immunity to these illnesses here in our community. And as soon as they decide to travel to the third world, they are a sitting duck for any of these kinds of infections that, back in the 30s and 40s, they killed kids. That's why we developed them, because they killed kids.
Okay.
Anne over there.
I wonder if the panel members could say something about strange eating practices among children that are particularly or can be particularly difficult for parents and for families. My wife and I have 9 grandchildren. They all eat pretty well, except for one who has some very strange behaviors. Sometimes won't eat at all. He's 8 years old now.
Yeah.
Sometimes he'll only eat steak, but only if the steak hasn't touched or been near any other foods. And it causes difficulty. Thank you.
I know an adult like that. Your food cannot, the foods are not allowed to touch.
I see a lot of picky eaters in the child development clinic. And I think as anyone who's ever practiced in general pediatrics will have seen lots and lots of kids who come in to see the pediatrician because, my child doesn't eat, or my child is a really, really picky eater, and, he's going to die, he's eating so little. And in almost all cases, when we weigh and measure the child and plot the growth on the growth chart, we see that somehow that child is existing on air because they continue to put on weight. And children actually do need less food. They go through a stage where they're growing so quickly as babies. You remember those nights when you put your baby to sleep in a sleeper that seems to fit perfectly well, and they wake up in the morning and their toes poking out the end of it, and they've literally grown an inch overnight. And when kids get to the toddler age, they're not growing as quickly, and the growth curve levels off a bit. So they don't need as much food, and so that can be one of the biggest reasons. But in cases where it's not typical, sometimes it can be, and Edmund might be able to talk about this more, but sometimes they're missing something in their diet, and they will be craving one particular type of food, and they'll go on a bit of a food jag. There was an amazing study done a long time ago now by dietitians. It was done over 30 years ago. And she put a whole pile of toddlers in a room, and just fed them whatever they wanted for 5 days. And so there was only healthy food on the table. There was no like junk food. But there was like, eggs and bananas and meat and cheese and fish and everything on the table. And the dietitians just stood back and they didn't do a thing. They didn't say, you need to eat your vegetables. They didn't do that. They just wrote down every single thing that the child ate. One kid ate 13 bananas one day. That's all, just 13 bananas. Another kid ate a dozen eggs. But over the course of the week, the dietitian said they could not have made up a healthier diet for the children. So they knew what to eat, but maybe they didn't do it all exactly every day right. So those are some of the normal reasons, and most kids are normal. Some kids will have extreme sensitivities to things, hypersensitivities to textures. And you might find that children who are really, really picky with their food, they will not eat anything crunchy or will not eat anything too chewy or will not eat yogurt because it's too smooth. You might also find they're extra sensitive in other areas. They don't like socks that have seams on. They're the kid that strips naked the second they come in the house because they don't like the feel of clothes on their skin. So there are children who have these hypersensitivities to things. And by hypersensitivity, I don't mean allergy. I just mean texture hypersensitivity. And that can really impact the kinds of foods that they eat. And then in the rare situation, it can be an actual condition like autism, where children are extremely, extremely particular. They really won't eat for days on end if you lose the specific plate or cup that they're used to eating or drinking out of. And that's abnormal, and that's rare, because most kids are normal, and most of the food preferences are related to normal child development. And so the first thing that you do when you have a kid who's picky or weird eating is go and see the family doctor and get the child weighed and measured and make sure they're growing properly, and look to see if they're exceptionally picky. You ask to see a dietitian so that the dietitian can make sure that your child is actually getting enough nutrients.
Sophie, do you want to add something to that, Evan?
That was very, very thorough, and I would agree that the picky eater is a very common scenario, which is completely benign usually. But in my world, I do see these extreme cases where it's been an early phase of a child's development, and they just haven't been exposed to the solids at the right time, and they lose that ability to deal with the texture. And it's really difficult. There's a body of literature that my gastroenterology colleagues are more familiar with on this, where once that phase has been bypassed, it's so hard to regain that. And those children end up seeing occupational therapists and other healthcare professionals for many, many years, just to get past this lost phase.
Sophie, over here.
I would just add that the CPS has really good handouts for parents and care providers on the Caring for Kids site about food issues. And one of the things they say, for example, is it's the adult's job to decide what the child eats, and it's the child's job to decide how much. So not falling into the scenario of the child only eats cookies or only eats this, because clearly as adults we're the ones providing our children the food. And it might mean that children miss a meal, but there's some just practical suggestions on that website.
Okay. Yeah, Fred?
Hi, really enjoying the talk tonight. My question is, I guess, more for Dr. Chan. It's a two-part question, and I'd like to know your take on the relationship between autoimmune diseases and allergies. I have a 12-year-old boy who is recently diagnosed with Hashimoto's, and I've been reading a lot about maybe celiac having a connection with it, but the conventional medical stream doesn't always accept that connection. So that was one part of the question. And when is it reasonable? Like you said, a lot of kids are over-tested for allergies. So when is it reasonable for parents to actually consider allergy testing and explore that avenue?
Okay, thank you. So for the first question, Kristen and I could answer aspects of that, but traditionally, the immune system has been viewed in terms of two sets of T cells. There's your Th1 cells and your Th2 cells. And the Th1 cells were more responsible for autoimmune conditions, whereas the Th2 for allergic conditions. But as the field of immunology has exploded with information, in the past several years we've learned that it's not so simple with the T cells. The T cells are the central gatekeepers in your immune system, and there's regulatory T cells that control these subsets of T cells. And so as a result, we see a different type of dysfunction that can result in the type of child you're describing who has both an autoimmune condition as well as an allergic condition. And an example that I see in the eosinophilic esophagitis clinic, for example, is a child with celiac disease, and then coincidentally, when they get their endoscopy and biopsy, are diagnosed with eosinophilic esophagitis. And that's brought those two conditions together. Having said that, I see a lot of children with allergic conditions, and it's not like I'm seeing an overwhelming number who also have autoimmune conditions. They're both fairly common conditions in the developed world. The second question, so allergy testing, the take-home point with allergy testing is it should all be based on history. And it's so fundamental to all areas of medicine, but I can't emphasize that enough, that if the history makes the clinician suspicious of a food allergy, then it's warranted to go down that path. But if the history is not suggestive of it, please don't, because the false positive rate for food allergy testing can be as high as 50 to 80%. So you can have all these children walking around with these labels when in fact they don't have that. And so when does the history start? Well, in the first year of life, it's usually milk or egg. And when you're introducing those foods, there's an immediate reaction, so something occurring typically within 2 hours that involves hives or difficulty breathing or vomiting and something like that. And then as you get older and the child is exposed to more different foods, then you could suspect it with those foods that are introduced that they're not otherwise eating. Asthma begins usually between 1 to 2 years of age, and there could be some environmental allergy testing that can be done with that. And then allergic rhinitis is school age. Atopic dermatitis is actually a skin barrier defect, so fundamentally it doesn't initially have anything to do with allergy, but then it puts the child at risk for developing allergy. The current thought is that they're exposed to allergens through their broken skin.
Okay, I think we have a couple more.
I'm going to come in here. I think we have time for a couple more questions and closing remarks.
Sure.
Hi, thank you. I appreciate you all coming. I have a 13-year-old son who struggles with depression and anxiety, and that came out when we were doing high-level rep hockey for many years. We were just living on this very stressful autopilot family. And one season in grade 6, he had a panic attack on the ice, and that was when it all came out. And he's going to turn 14 in a couple of weeks, and I just want to bring it to the panel. What can we do as parents to support him further along? I mean, we're trying to reduce his video gaming time because he always tells us that that's his way to shut off because he's very overwhelmed with his schoolwork. He doesn't want to go back to hockey because it's too stressful, and he's quite a perfectionist. So, and now it always happens just after Christmas. He starts saying, I don't want to go to school. I'm feeling stressed out. I just want to sleep. I just want to play video games. I want to watch movies all day. So I just, as parents, we struggle with, like, we've gone through, like we went through ER 1 year because we were concerned for his life. And we had a triage and all that. But at the time at UBC, the psychiatrist deemed him not, high priority, mild to moderate depression and anxiety. So we were able to have him see a psychiatrist through my brother, because we have a long history of depression in my family. So, I just want to pose to the panel, what can we do as parents to support him and into his adulthood?
I'm not sure. I know Barbara, you're nodding, and Margaret, you talked about mental health as well.
Yeah. That is a really tough one. And we hear that so commonly in Emerge. And you've done all the right things. The biggest thing is just to be there for them. And as much as sometimes they don't want to talk about it, you got to make them turn off the Game Boy. Yes, is his way of sort of blocking things and maybe feeling safe in his little cocoon. But you do have to start to teach him the adult skills about how you deal with stress. For sure, take a big step away from ice hockey or whatever other almost elite sport the kids are in. Big step away. There's a whole lot more to physical activity than elite sports. But help him, he's got to choose, the rule should be a new activity. And you can sit down and help him choose that. And whether it's something that their friends do or something maybe no friends do, a totally different thing, swimming lessons, whatever. He's got to do something physical because he's got to get his heart going and get his body moving so that he's going to be tired at night and go to sleep. The games can't be used for that calming, soothing thing. He needs to make himself go to sleep. So again, start to just help him come up with his own schedule about how to get back into a bit of a routine that's going to make him feel, or help him feel safe again. It's always tough when you're seeking out mental health assessments and you get stuck on these wait lists. Very, very tough. It is one of the times where, I really encourage parents, if they have the resources, to think about private psychology assessments. I think psychology assessments are and can be magical. They really give you as a parent, and I think kids as well, a very clear idea of where that child sees himself in their world and how they see their world around them, and what some of the different stressors are for them. Psychology assessments that I've read through my child protection work have, to me, been far more valuable. I'll tell you when I said this, who's taking... Sometimes, not always, but you seem to get a lot of more information out of them than some of the psychiatry assessments I've read. Sometimes the psychiatry assessments, certainly they have a very important place with some of the clear psychiatric illnesses, but for most kids who are dealing with anxieties and stress in life, the psychology assessments are a lot more in depth. And there is generally not as much of a focus on medication. Mm-hmm. Barb, do you help?
I think the only other thing I'd add, is that every community in the province has a child and youth mental health team, and they have therapists there as well as psychiatrists. And I think, if you haven't accessed that route for anyone who's got a child suffering from mental health conditions, they really are a tremendous resource. And I guess because, when we're talking about kids who are getting older, so young adults and youth, you want to start, as Margaret's suggesting, giving them tools that they can help themselves. And they're definitely, through child psychiatry at UBC, or at Children's Hospital, they have some great group programs for management of anxiety that kids can access after school that are really, really helpful. There's also some really good resources through our library at Children's Hospital and through the Sunny Hill Library. Sunny Hill Library is fantastic. SHERC, S-H-E-R-C. You go on it, you click on what you want. We mail it to you for free with a postage-paid envelope. Mm-hmm. It's like the best deal in town for resources for things. And we have, one of the things we carry is an anxiety disorders workbook that was produced at Children's Hospital by Dr. Jane Garland and some of her team. And there's one now for teenagers as well that can be really helpful. So first go and make sure you've got some professional help to know what you're dealing with. And then maybe start to look at what the other resources are for helping all of our children manage their mental health. So there's one good study going on right now at Children's in child psychiatry looking at mindfulness-based training to manage some of these issues in youth. And it's really showing some promise. So that's something I would definitely recommend because there's no side effects to that. But number one, I would go to child and youth mental health and make sure that you're on the right track. It's not something you want to manage on your own.
Okay, we have time for one more question.
Okay, so my question is probably best addressed by Dr. Fitzgerald. I am a physiotherapist in a community pediatric setting, and I'm wondering about developmental coordination disorder, or DCD, which I've heard a colleague refer to as the new autism in the sense that it's kind of being more widely recognized and more widely diagnosed, and the diagnostic criteria is changing. So kind of up till now as therapists, everyone has always kind of assumed that DCD diagnosis of exclusion. If nothing else could explain their motor issues, then you could consider DCD as a diagnosis. But now I understand that the DSM has changed so that you could have a DCD diagnosis in conjunction with impaired cognitive abilities. And that's always kind of been our golden ticket, because we use that cognitive ability to teach the child skills like riding a bike. You break it down into its bare bones tasks,
right,
and then build it up. But now if we can't assume that a child with DCD has typical cognition for their age, how can we really support them in fostering their motor learning?
So this is it. So for those of you who've never heard of it, which I'm sure is most of you, developmental coordination disorder is a disorder that is more recently recognized. And you would have known it when you were growing up as that kid in the class who always tripped. The one who just could not make it from his desk to the teacher's desk without knocking over the hamster cage and the aquarium and always got picked last for teams. So kids who have significant fine motor, so what you do with your hands, and gross motor, clumsiness, and delays. And as you're suggesting, we used to say that it had to be something that, like kids with an intellectual handicap, or in the old jargon, mental retardation, those kids were also clumsy, but they were slow in everything, so we didn't call it developmental coordination disorder. And now with the new DSM, they've broadened the diagnostic criteria. And in one way, it's one time when it's kind of good to broaden the criteria, because what they're saying is that if you think that the child's clumsiness and handwriting difficulties and fine motor difficulties are really, really a big factor that are impacting his life, even more than his learning disability or his intellectual slowness or other things, then call it developmental coordination disorder, because it helps people who are supporting him understand him better. So it helps the teacher know that you need to give him time and a half to write tests because he can't print as quickly as other children. Or you need to give him a scribe in class. You need to give him a laptop so that he can learn to type and not have to worry about printing anymore. So in that way, it can be helpful that we've broadened the diagnosis and really put it back into people's purvey, like you, physical therapists, who can say, is this really impacting the child? But the other thing I want to say about developmental coordination disorder, because I had 2 cases yesterday, actually, such a timely question, is I said to these parents, I know that right now with your 10-year-old, it really matters that he is the slowest kid when they go out to run, and he always gets made it, and then he's it for the whole recess because he can never catch anybody. And it really, really matters right now. But if you think about all the people who are your friends, do you know what age they were when they rode a bike, or whether they even know how to ride a bike now, or how fast they are at running? It's a condition that really, really affects children. And I like to reassure parents that if they are smart, it's not going to affect them later. If it's part of an intellectual delay, obviously it is. But that it's something we've made quite a big deal about for children. And we want to support them, but we want to also reassure parents that it's not going to be as big a thing for them when they're older. But still, I'm in favor of recognizing these kids, because I think when you have a kid who's got all these brilliant ideas and he's dying to get them out on the paper, and he gets 20% on his history exam because he actually can't write fast enough to put all these wonderful ideas on the paper, I want to make sure he's got another strategy to allow him to express himself.
Okay, just before we wrap up, I want to have each panelist offer one bit of advice that maybe... yeah, I'm going to start at that end, actually. Edmund, you're the lucky one. One bit of advice that you would want to give to parents.
Okay, so a very simple and clear take-home message I'd like to give is to not delay the introduction of any solid food beyond 6 months, including peanut, because it does not prevent development of allergy.
All right.
And mine would just be active and be active with your children. Do it together.
And to be a bit more specific, I guess a take-home message for concussions is you can have a concussion without loss of consciousness. And if you know a child who has one or see one, please have them see a physician. And don't return to playing sports.
Okay.
I'm going to be way more general. I'm going to say just love your kids and spend time with them and play with them and read them and enjoy them. And think about all of our kids in our community who maybe need our support through the way that we vote and the way that public policy gets decided. And know that your kids' happiness and your happiness is actually really directly related to the health and happiness of all our children.
All right. Thank you very much to all of our panelists for taking the time tonight.